Hey guys, tonight we're diving into the charming world of Victorian pregnancy, where congratulations were basically condolences and morning sickness was the least of your worries. We're talking about an era when getting pregnant was like playing Russian roulette, except the gun had 5 bullets and society kept reloading it for you. So go ahead and like the video if you're ready for some delightfully morbid history, and subscribe if you enjoy learning about humanity's impressive talent for making natural processes unnecessarily deadly. Drop a comment letting me know where you're watching from. It's always wild to see who's brave enough to join me for these cheerful bedtime stories about historical disasters. Now settle in, maybe grab some tea, and let's explore why Victorian England treated pregnancy like an extreme sport that nobody signed up for but everyone was expected to excel at. So you think childbirth is tough today? Oh honey, that's precious. Like complaining about a paper cut while someone's getting their leg amputated with a rusty spoon. So you're a woman in Victorian England, and congratulations, you're pregnant. Time to start planning your funeral. Not being dramatic here, though the Victorians certainly were about everything else, but statistically speaking, you had about the same chance of surviving childbirth as a Roman soldier had of surviving his first major battle. Except the soldier got a sword and some training. You got a corset and some prayers. Let's paint the picture, shall we? The year is 1840, something. Victoria's on the throne looking perpetually unamused, and you've just realised you've missed your monthly visitor. In modern times, this might prompt a trip to the pharmacy for a little plastic stick. In Victorian England, it prompted your mother to start quietly shopping for morning clothes. Black was always in season when someone in the family was expecting. First things first, you don't get to find out you're pregnant from some convenient home test.
Oh no.
You get to wait and wonder while your body transforms into something you no longer recognize. Morning sickness. That's just your constitution being delicate, as all proper ladies should be. Your corset getting tighter. Well, that's what stays are for, to keep everything properly contained, including your ability to breathe. The Victorians had a fascinating relationship with the female form. They wanted it tiny-waisted, submissive, and mysteriously capable of producing endless children, preferably without making any unseemly noises in the process. When you finally work up the courage to mention your suspicions to your husband, because discussing bodily functions, even life, creating ones, was about as socially acceptable as strip dancing in church, he'll likely respond with the emotional range of a well-dressed turnip. Pregnancy wasn't something husbands were expected to be involved in beyond the initial 5 minutes of creation. Their job was to pace around looking important and occasionally ask if you needed more pillows. Your job was to not die, preferably while maintaining perfect posture, and never once admitting that growing a human being inside your torso might be mildly uncomfortable. But let's talk about what you're really up against here. This isn't just about the pain. Though sweet mother of pearl, we'll get to that. It's about entering a medical system that treated women's bodies like mysterious, slightly defective clock, making projects that occasionally produced babies if you wound them correctly and prayed hard enough. The medical establishment in Victorian England approached pregnancy with all the scientific rigour of a saints. Your local doctor, assuming you could afford one, had received his training at a time when the prevailing theory was that women were basically just smaller, more emotionally unstable men with inconvenient monthly cycles and an alarming tendency to faint at the sight of their own ankles. The idea that pregnancy might require specialized medical knowledge was radical thinking. Most doctors knew about as much about childbirth as you knew about brain surgery, which is to say they could spell it correctly most of the time, and that was about it. Medical school in the Victorian era was a fascinating exercise in confident ignorance. Future doctors learned that disease was caused by bad air. Miasma, they called it, which sounds like an Italian sports car, but was actually their catch, all explanation for why people kept inconveniently dying. They learned to bleed patients for everything from headaches to heartbreak. They learned that cleanliness was optional, hand washing was for servants, and that the best way to deliver a baby was with unwashed hands, supreme confidence, and absolutely no understanding of what those screaming sounds meant. Germ theory. That radical nonsense wouldn't catch on for decades. The idea that tiny invisible creatures might be causing infection was about as believable as suggesting that the moon was made of green cheese. Except the cheese theory probably would have gotten more serious consideration. So when your doctor arrived to attend your birth, he came fresh from his previous patient, maybe someone with consumption, perhaps a fellow with syphilis, hands unwashed, instruments unsterilized, an attitude fully convinced that he was God's gift to the medical profession. But before we get to the main event, let's talk about the 9 months of prenatal care you could expect. And by prenatal care, I mean a series of increasingly bizarre restrictions designed to ensure that you remained as passive and ornamental as possible while your body performed its mysterious biological functions. Exercise? Absolutely not. Physical activity might jostle the baby loose, and besides, ladies didn't sweat. They might develop a gentle glow if the temperature exceeded freezing, but actual perspiration was vulgar. So you spent your pregnancy sitting perfectly still, reading improving literature, and practicing the art of breathing shallowly so as not to strain your delicate constitution. Your muscles atrophied, your stamina disappeared, and your body prepared for childbirth about as effectively as a hothouse orchid prepares for a hurricane. Diet? Well, that was simple. You ate whatever your husband decided you should eat, which was usually based on whatever folk wisdom had been passed down through generations of people who thought scurvy was caused by moral failings. Too much meat might make the baby aggressive. Too many vegetables might make it weak. Spicy food could cause the child to be born with a violent temper. Sweet food might result in a baby that cried too much. By the time everyone finished offering their expert nutritional advice, you were basically left with plain bread, mild tea, and the occasional boiled egg if you'd been especially virtuous that week. And the clothes! Oh, the clothes were a special kind of torture device masquerading as fashion. Your corset, that architectural marvel of whalebone and determination, didn't get abandoned just because you were growing a human being. Oh no, that would be unseemly. Instead, it got adjusted, slightly, to accommodate your expanding form, while still maintaining the illusion that women were naturally shaped like hourglasses with breathing difficulties. The Victorian maternity corset was an engineering marvel in the same way that medieval torture devices were engineering marvels. Technically impressive, but you wouldn't want to experience them personally. These contraptions were designed to support your growing belly, while simultaneously compressing your ribcage, restricting your breathing, and ensuring that your spine maintained the fashionable S curve that suggested both refinement and a complete disregard for spinal health. Wearing one of these devices was like being hugged by a very proper, very determined python. It squeezed in all the wrong places while providing support in areas that didn't need it, and it made simple activities like sitting down, standing up, or drawing a full breath into minor athletic achievements. But heaven forbid you should appear in public without proper support. A woman showing her natural, uncorseted shape was scandalous enough to close down entire tea shops and send elderly ladies reaching for their smelling salts. Speaking of smelling salts, let's talk about the medical accessories that were considered essential for any pregnant woman of proper breeding. Smelling salts for when you inevitably swooned from lack of oxygen. Laudanum for when the smelling salts weren't quite enough to manage the constant discomfort of being compressed like a Victorian sardine. And a selection of tonics, tinctures, and patent medicines that contained everything from alcohol to cocaine to ingredients that would make a modern pharmacist weep with terror. These miracle cures were advertised with the kind of bold confidence that only comes from an era when medical regulation consisted of, well, it hasn't killed anyone yet that we know of. Dr. Pemberton's miracle elixir for expectant mothers contained enough morphine to sedate a small horse. Mrs. Hartwell's strengthening tonic was basically gin with a fancy label. And Professor Blackwood's prenatal vigor treatment was a mysterious brown liquid that smelled like turpentine and cost more than most people earned in a month. The advertisements for these products were masterpieces of creative writing. "Ensures a painless confinement," they proclaimed. "Guarantees a healthy complexion throughout your delicate condition. Prevents unsightly swelling and maintains ladylike composure." They promised everything except what you actually needed, which was basic medical knowledge, sanitary conditions, and maybe a doctor who had washed his hands sometime in the previous decade. But let's say you've made it through 9 months of restrictive clothing, questionable medical advice, and a diet that would make a modern nutritionist break down in tears. Let's say you've survived the constant warnings about stairs, dangerous, fresh air, suspiciously healthy, and reading too many novels might overstimulate the brain and cause complications. Now comes the really fun part, actually having the baby. Victorian childbirth was approached with all the medical sophistication of a barn raising. The process was called confinement, which sounds like you were being punished for something. And in many ways you were. You were confined to your bedroom, confined to your bed, and confined to whatever passed for medical care in your particular corner of the empire. If you were wealthy, you might have a proper doctor attend your birth. If you were poor, you got whoever was available, which might be the local midwife, the neighbour lady who'd had 6 children of her own, or quite possibly nobody at all except your husband pacing nervously in the hallway and occasionally shouting helpful suggestions through the door. The wealthy woman's birthing experience was a theatrical production with all the pomp and circumstance the Victorians could muster. The bedroom was transformed into a medical stage set, complete with special linens that would be thrown away afterward, because blood was considered hopelessly vulgar and certainly couldn't be allowed to stain anything of value. The curtains were drawn tight to create an atmosphere of mysterious feminine secrecy. Candles provided the only light, because gas lamps might be too stimulating for a lady in her delicate condition. The doctor arrived like a Victorian superhero, complete with black bag, serious expression, and an impressive array of medical instruments that looked like they'd been borrowed from the Spanish Inquisition. He wore his best coat, because appearing at a birth was a social occasion as much as a medical one. His hands, as mentioned, were about as clean as his understanding of bacterial infection, which is to say not at all. The birthing process itself was surrounded by enough ritual and superstition to make a medieval witch trial look rational. The labouring woman wasn't allowed to make noise. Ladies didn't scream. They might emit genteel moans if absolutely necessary, but preferably they suffered in dignified silence. She wasn't allowed to move around. Lying flat on her back was considered the proper position, despite the fact that gravity and basic human anatomy suggested this was possibly the worst position imaginable for getting a baby out of a human body. Pain relief. Well, that was a complicated subject. On one hand, pain in childbirth was considered natural, even necessary. It was part of Eve's punishment for that unfortunate business with the apple, and who were mere mortals to interfere with divine justice. On the other hand, watching someone you theoretically cared about writhe in agony for 18 hours was somewhat uncomfortable for everyone involved. The compromise was laudanum, that miracle drug of the Victorian era. Laudanum was liquid opium, basically, and it was prescribed for everything from headaches to heartbreak to the general malaise of being a woman in the 19th century. For childbirth, it provided just enough pain relief to take the edge off while leaving you conscious enough to follow the doctor's increasingly frantic instructions. The side effects of laudanum during labour were about what you'd expect from giving opium to someone trying to push a human being out of their body. It slowed down labour, made it harder to push effectively, caused respiratory depression in both mother and baby, and generally turned what should have been a natural biological process into a pharmaceutical adventure that would make a modern anesthesiologist break out in a cold sweat. But laudanum was the sophisticated option. Many women got nothing at all except perhaps a leather strap to bite down on, and some well-meaning advice to think pure thoughts and remember their duty to God and country. The actual medical intervention during Victorian childbirth was a fascinating combination of aggressive incompetence and benign neglect. If everything was going smoothly, which it rarely was, given the complete lack of understanding about things like infection, proper positioning, or basic hygiene, the doctor might simply stand there looking important while nature took its course. If complications arose, however, things got interesting in the worst possible way. Forceps were the Victorian solution to difficult births, and using them required about as much finesse as playing the violin with boxing gloves. These metal instruments were designed to grab the baby's head, and pull it out when pushing wasn't working effectively. In the hands of a skilled practitioner who understood anatomy and had some experience with the procedure, forceps could be life-saving. In the hands of the average Victorian doctor, they were more like medieval can-openers with delusions of medical legitimacy. The procedure for using forceps was straightforward in theory and horrifying in practice. The doctor would insert these metal blades around the baby's head, lock them together, and then pull with whatever force seemed appropriate for the situation. There was no anesthesia for the mother, beyond perhaps another dose of laudanum, no understanding of how much force was too much, and no real concern for what all this metal manipulation might be doing to either the mother's anatomy or the baby's developing brain. Successful forceps delivery could save both mother and child when a birth was truly stuck. Unsuccessful forceps delivery could result in skull fractures, brain damage, massive tears in the birth canal, and the kind of bleeding that turned birthing chambers into crime scenes. The Victorian medical response to these complications was usually to apply more force and hope for the best. If forceps weren't doing the job, the next step was often even more dramatic. Caesarean section was technically possible in the Victorian era, but it was essentially a death sentence with surgical complications. The procedure was performed without proper anesthesia, without understanding of sterile technique, and without antibiotics to prevent the inevitable infection. The survival rate for C-sections was roughly equivalent to the survival rate for being struck by lightning while being attacked by bears. Most doctors preferred to avoid surgery altogether and instead relied on what they called version, manually turning the baby inside the womb to facilitate delivery. This procedure involved the doctor reaching inside the birth canal with his unwashed hands and attempting to rotate a slippery, uncooperative baby into a better position. It was about as pleasant as it sounds and roughly as successful as you might imagine. The version procedure was performed without anesthesia, naturally, because pain was considered a necessary part of the birthing process. The mother was expected to remain still and quiet, while the doctor essentially performed internal gymnastics with her unborn child. The risks included tearing of the uterine wall, detachment of the placenta, cord prolapse, and a variety of other complications that could result in the death of mother, child, or both. But let's say everything went relatively smoothly. Let's say the baby was born alive, the mother survived the immediate trauma of delivery, and everyone was ready to celebrate this minor miracle. The celebration was probably premature, because the real danger was just beginning. Childbed fever, or puerperal sepsis as it was medically known, was the serial killer of Victorian maternity wards. This infection typically developed within a few days of delivery and was caused by the same bacterial contamination that the medical establishment refused to acknowledge existed. The symptoms started innocently enough. Slight fever, general malaise, the kind of discomfort you might expect after pushing a human being out of your body. Then things escalated quickly. The fever climbed higher. The new mother developed chills, abdominal pain, and a general sense that something was terribly wrong. Her pulse raced. Her breathing became labored. The infection spread through her bloodstream like wildfire through a drought-stricken forest. And within a week of what should have been the happiest day of her life, she was often dead. The Victorian medical response to childbed fever was a textbook example of how to make a bad situation catastrophically worse. The prevailing treatment was bleeding, because obviously what a woman dying of infection needed was to lose more blood. They might also prescribe calomel, a mercury-based compound that was toxic enough to make the original infection seem like a minor inconvenience. Some doctors tried purging. Violent diarrhea was considered therapeutic for reasons that made sense only to people who thought disease was caused by an imbalance of bodily humours. Others preferred blistering, which involved applying heated cups to the skin to draw out the bad blood that was supposedly causing the problem. These treatments had roughly the same success rate as throwing holy water at a house fire, but they were applied with the kind of confident authority that only comes from a complete misunderstanding of basic human biology. The tragedy of childbed fever was that it was almost entirely preventable with basic hygiene. Hand washing, clean instruments, sterile conditions, simple measures that could have saved thousands of lives. but suggesting that doctors wash their hands was insulting to their professional dignity. The idea that gentlemen's hands could be unclean was so socially unacceptable that it was easier to let women die than to acknowledge that proper hygiene might be important. Ignaz Semmelweis, a Hungarian physician working in Vienna, made the connection between hand washing and reduced mortality rates in maternity wards. He instituted a policy of chlorine hand disinfection for doctors and medical students, and the death rate from childbed fever dropped dramatically. His reward for this life-saving discovery: professional ostracism, career destruction, and dismissal from his position. The medical establishment found his suggestions so offensive that they preferred to maintain their lethal practices, rather than admit they might have been wrong. But even if you survived the immediate dangers of childbirth and managed to avoid childbed fever, your troubles were far from over. The recovery period was its own special kind of endurance test, governed by medical theories that seemed designed to prevent healing rather than promote it. Victorian medicine decreed that new mothers should remain flat on their backs for weeks after delivery. Movement was dangerous, fresh air was suspicious, and getting out of bed was practically criminal. This enforced bed rest was supposed to allow the body to recover, but in practice it promoted blood clots, muscle atrophy, and a general decline in physical condition that made subsequent pregnancies even more dangerous. The new mother was fed a diet that would make modern nutritionists weep with frustration. Rich foods were forbidden because they might overstimulate the system. Meat was suspect because it might inflame the passions. Vegetables were questionable because they might cause digestive upset. The approved postpartum diet consisted mainly of gruel, weak tea, and toast so dry it could have been used as building material. Meanwhile, the baby, assuming it had survived the delivery, was handed over to a wet nurse if the family could afford one, or expected to thrive on a mother whose body was depleted by poor nutrition, blood loss, and the general trauma of Victorian childbirth. Breastfeeding was considered somewhat vulgar among the upper classes, and there was a thriving industry in artificial feeding methods that had roughly the same nutritional value as flavoured sawdust. The infant mortality rate in Victorian England was staggering. Roughly 1 in 4 children died before their first birthday, and many of those deaths occurred within days or weeks of birth. The causes were varied but predictable: malnutrition, infection, accidents, and diseases that would be easily treatable today, but were death sentences in an era when medical intervention was often more dangerous than the original problem. For mothers who lost children, and most women lost at least one, the Victorian response was a combination of religious resignation and social expectation to produce replacement babies as quickly as possible. Grief was private, mourning was brief, and the assumption was that women would continue having children until they either succeeded in producing a few survivors or died in the attempt. The psychological toll of repeated pregnancies, frequent infant deaths, and constant physical danger was rarely acknowledged. Women were expected to approach each pregnancy with the same cheerful optimism they might bring to a church picnic, despite the fact that their previous experiences had probably been more traumatic than most battlefield injuries. Depression, anxiety, and what we might now recognize as post-traumatic stress disorder were dismissed as feminine weakness or moral failings. Women who couldn't maintain perfect domestic tranquility while processing the trauma of multiple near-death experiences were considered deficient in character rather than overwhelmed by circumstances that would challenge anyone's mental health. The social expectations surrounding pregnancy and motherhood were as rigid as the corsets that compressed women's bodies. A proper Victorian woman was supposed to embrace pregnancy with quiet joy, endure labour with dignified silence, recover with grateful submission, and immediately begin preparing for the next pregnancy with renewed enthusiasm. Any deviation from this script was evidence of moral failure or constitutional weakness. Women who expressed fear about childbirth were considered cowardly. Women who complained about pain were considered weak. Women who questioned medical advice were considered rebellious. Women who wanted some control over their own reproductive decisions were considered dangerously radical. The entire system was designed to keep women passive, compliant, and maximally vulnerable to the very processes that were killing them in alarming numbers. The class differences in maternal mortality were stark but predictable. Wealthy women had access to doctors, private rooms, and better nutrition, but they also had access to more aggressive medical intervention, which was often as dangerous as it was expensive. Poor women had less access to medical care, but also less exposure to harmful medical practices. They were more likely to be attended by experienced midwives who understood the normal progression of labor, and were less likely to intervene unnecessarily. Working-class women often continued physical labor well into pregnancy, which actually prepared their bodies better for the demands of childbirth than the enforced inactivity prescribed for their wealthier sisters. They ate simpler but often more nutritious food, weren't constrained by tight, laced corsets, and had fewer resources to spend on patent medicines that were more dangerous than helpful. But poverty brought its own risks. Malnutrition weakened the body's ability to cope with pregnancy and childbirth. Overcrowded living conditions increased the risk of infection. Lack of access to any medical care at all meant, when complications arose, there was often no help available until it was too late. The rural-urban divide also created different patterns of risk. Country women were more likely to be attended by traditional midwives who had practical experience but no formal training. City women had access to more medical professionals, but also greater exposure to hospital, acquired infections and more aggressive medical intervention. The hospitals themselves were often more dangerous than home births. Victorian hospitals were breeding grounds for infection, staffed by doctors who moved between patients without washing their hands, and managed according to theories that prioritized institutional convenience over patient safety. The mortality rates in hospital maternity wards were often higher than for home births, but hospitals were considered more modern and scientific, so they attracted patients who could afford to pay for the privilege of increased risk. The irony of Victorian childbirth was that the more medical attention you could afford, the more likely you were to die from it. The wealthy woman with her trained physician, private room, and access to the latest medical instruments was statistically more likely to die in childbirth than the poor woman who gave birth at home with only her neighbour for assistance. This wasn't because poverty was protective, quite the opposite. It was because Victorian medical intervention was often more harmful than no intervention at all. The unwashed hands of the society doctor were more dangerous than the clean but unschooled hands of the village midwife. The forceps delivery performed by a physician who had read about the procedure in textbooks was more likely to cause fatal complications than the natural delivery attended by a woman who had personally witnessed hundreds of births. The patent medicine industry that flourished during the Victorian era was particularly predatory when it came to pregnant women. These were people who were scared, uncomfortable, and desperate for anything that might ease their situation, which made them perfect targets for every quack remedy and miracle cure that enterprising charlatans could devise. The advertising for these products was a masterclass in exploiting fear and hope. Diga, Morrison's miracle compound ensures easy labor and healthy babies. Professor Caldwell's prenatal elixir prevents all complications or messes. Henderson's strengthening tonic guarantees a painless delivery. They promised everything and delivered nothing except lighter purses and often dangerous side effects. Many of these so-called medicines contained alcohol, opium, cocaine, mercury, and other substances that were harmful to both mother and developing child. But they were marketed with the kind of authoritative confidence that suggested scientific backing, complete with testimonials from satisfied customers and endorsements from medical professionals who may or may not have existed. The regulation of medical practice and pharmaceutical products was essentially non-existent. Anyone could call themselves a doctor, set up practice, and begin treating patients with whatever methods they thought might work. Anyone could mix up a batch of patent medicine, give it an impressive name, and sell it to desperate people looking for relief from genuine medical problems. This created an environment where dangerous incompetence flourished alongside genuine medical knowledge, and patients had no reliable way to distinguish between the two. The doctor with years of training at a respected medical school might be just as dangerous as the self-taught practitioner who had learned his trade from a correspondence course. and the expensive patent medicine might be just as harmful as the home remedy passed down through generations. The lack of reliable birth control made the situation even more desperate. Women had no effective way to prevent pregnancy, space their children, or limit their family size according to their health or economic circumstances. Once married, they could expect to spend most of their reproductive years either pregnant, recovering from childbirth, or grieving dead children. The methods that existed for preventing pregnancy were either unreliable, dangerous, or socially unacceptable. Withdrawal was unreliable and required male cooperation that wasn't always forthcoming. Barrier methods were primitive and often ineffective. Herbal remedies ranged from useless to toxic, and discussing any of these options was considered so improper that most women had to rely on whispered advice from female relatives or friends, which wasn't necessarily accurate or safe. The result was that Victorian women faced an endless cycle of pregnancy and childbirth that continued until menopause or death, whichever came first. Large families were the norm, but not necessarily by choice. Many women were essentially trapped in a system that used their bodies as baby-producing machines until those bodies finally broke down under the strain. The cultural celebration of large families masked the grim reality of what this meant for individual women. Society praised mothers who produced numerous children, but it didn't acknowledge the physical and emotional toll of repeated pregnancies, the grief of frequent infant deaths, or the constant fear that each pregnancy might be the last thing they ever experienced. Religious doctrine reinforced these social expectations by teaching that childbirth was both a woman's sacred duty and her punishment for original sin. Pain in labor was not only expected but divinely ordained, which made seeking relief seem like questioning God's plan. Large families were seen as blessings, which made limiting family size seem selfish or faithless. The medical profession, such as it was, supported these cultural attitudes with pseudo-scientific theories that justified treating women as inherently fragile, mentally inferior, and designed primarily for reproduction. Victorian medical textbooks described women as essentially defective men, governed by their reproductive systems in ways that made them unsuitable for serious mental or physical activity, but perfectly designed for the passive endurance of pregnancy and childbirth. These attitudes created a self-reinforcing cycle where women were weakened by social restrictions, medical ignorance, and cultural expectations, which made them more vulnerable to the dangers of pregnancy and childbirth, which reinforced the belief that women were naturally weak and needed to be protected from everything except the one activity that was actually killing them in alarming numbers. The few voices that questioned this system were dismissed, ridiculed, or actively suppressed. Women who advocated for better medical care, birth control, or reproductive choice were considered radicals who were threatening the natural order of society. Doctors who suggested that current practices might be harmful to women's health found themselves professionally isolated. Reformers who proposed changes to reduce maternal mortality were accused of undermining traditional family values. Meanwhile, the death toll continued to climb. In some areas of Victorian England, maternal mortality rates reached levels that would be considered catastrophic even by medieval standards. One woman in every 20 to 30 who gave birth could expect to die from the experience, and those numbers didn't include women who died from pregnancy related complications before going into labor. The ripple effects of these deaths extended far beyond the women themselves. Children who lost their mothers faced significantly higher mortality rates, especially infants who depended on breastfeeding. Families were torn apart, household economics were disrupted, and surviving children often faced poverty, neglect, or abandonment when their primary caregiver died. The remarriage patterns that developed in response to high maternal mortality created complex family structures where children from multiple marriages lived together under the care of stepmothers who might be only slightly older than their oldest stepchildren. These blended families faced unique challenges in an era when family relationships were supposed to be simple and clearly defined. The psychological impact on surviving family members was rarely acknowledged but must have been devastating. Children who watched their mothers die in childbirth learned to associate pregnancy with death, which affected their own attitudes toward marriage and family formation. Men who lost wives to childbirth faced the practical challenge of managing households and raising children while processing their own grief and trauma. The economic implications of high maternal mortality were also significant. Women's domestic labor was essential to household functioning, and their deaths created economic hardship that extended beyond the immediate family. The cost of wet nurses, housekeepers, and childcare providers could bankrupt families that had previously been financially stable. The broader social costs included the loss of women's contributions to their communities, the disruption of social networks, and the creation of a culture of fear around pregnancy and childbirth that affected women's life choices and opportunities. When pregnancy was essentially a form of Russian roulette, rational women might choose to avoid marriage altogether, rather than risk death in childbirth. But avoiding marriage wasn't a realistic option for most Victorian women. Economic dependence on male relatives made marriage a survival strategy rather than a romantic choice, and social expectations made unmarried women objects of pity or suspicion. Women were caught between the necessity of marriage for economic security and the deadly risks that marriage inevitably brought. The legal framework surrounding marriage and reproduction gave women no control over their own bodies or reproductive decisions. Once married, a woman's body legally belonged to her husband, who could demand sexual access regardless of her health, desires, or circumstances. Rape within marriage wasn't legally recognized, and women had no right to refuse sexual contact, even when pregnancy might be dangerous to their health. This legal powerlessness extended to medical decisions as well. Husbands could override their wives' preferences about medical care, choice of practitioner, or treatment options. Women couldn't consent to or refuse medical procedures on their own behalf, which meant that dangerous interventions could be performed against their will, while beneficial treatments could be denied if their husbands disapproved. The intersection of legal, medical, and social powerlessness created a situation where Victorian women faced the risks of pregnancy and childbirth with virtually no agency over their own experiences. They couldn't prevent pregnancy, couldn't choose their medical care, couldn't make decisions about their own treatment, and couldn't even be certain that their wishes would be respected if they became unable to communicate during labor. This systematic disempowerment was justified by elaborate theories about women's inherent nature and social role, but the practical effect was to maximize women's vulnerability to preventable death and suffering. The very people who claimed to be protecting women by restricting their choices and controlling their behavior were creating conditions that made pregnancy and childbirth far more dangerous than they needed to be. The irony was that many of the cultural practices designed to protect women's virtue and preserve their delicate constitutions were actually undermining their physical health and survival chances. Tight, laced corsets weakened core muscles needed for labor. Enforced inactivity reduced stamina and fitness. Social restrictions on discussing bodily functions prevented women from sharing information that might save lives. The cult of feminine delicacy that characterized Victorian culture was particularly deadly when applied to pregnancy and childbirth. The idea that proper ladies were too refined to experience physical discomfort, too pure to discuss bodily functions, and too fragile to endure normal human experiences created expectations that were impossible to meet and dangerous to attempt. Women were caught in an impossible bind. They were expected to be simultaneously strong enough to survive repeated pregnancies and childbirth without complaint, but delicate enough to need protection from any activity more strenuous than embroidery. They were supposed to be instinctively knowledgeable about motherhood while being kept ignorant of basic information about their own bodies. The medical profession's attitude toward women's pain was particularly revealing of broader social attitudes. Pain in childbirth was considered natural and even beneficial, building character and fulfilling divine purpose. But pain from tight-laced corsets, restrictive clothing, and enforced inactivity was ignored or dismissed as feminine weakness. This selective concern about women's suffering reflected deeper assumptions about women's nature and value. Pain that served male interests, by ensuring that women remained sexually available and reproductively productive, was celebrated as natural and necessary. Pain that interfered with women's ability to fulfill social expectations was dismissed as imaginary or self-indulgent. The Victorian approach to pregnancy and childbirth was ultimately a reflection of a society that valued women primarily for their reproductive capacity, while simultaneously creating conditions that made reproduction as dangerous as possible. Women were expected to risk their lives repeatedly to produce children, but they weren't given the information, resources, or support they needed to survive the process. The tragedy wasn't just the individual deaths, devastating as they were, but the systematic nature of the problem. These weren't random misfortunes or unavoidable tragedies. They were predictable consequences of social, medical, and legal systems that prioritized everything except women's health and survival. The knowledge and techniques that could have prevented most of these deaths already existed in some form. Traditional midwives had accumulated centuries of practical experience about normal birth and when to intervene. Basic hygiene practices could have prevented most cases of childbed fever. Simple changes in positioning and movement during labor could have reduced complications. Better nutrition and less restrictive clothing could have improved women's physical condition for childbirth. But implementing these improvements would have required acknowledging that women's health and survival were important enough to challenge established medical authority, social conventions, and economic interests. It would have meant admitting that the cultural practices that supposedly protected and honored women were actually killing them. The resistance to change was fierce and sustained. Every suggestion for improvement was met with arguments about tradition, natural law, divine will, and social stability. Reformers were accused of undermining civilization itself by proposing that women's lives might be worth preserving through practical measures, rather than moral exaltation. The few improvements that did occur during the Victorian era happened slowly and against considerable opposition. The gradual acceptance of hand-washing in medical practice took decades to implement and was resisted as an insult to physicians' professional dignity. The development of safer surgical techniques was slowed by the belief that pain served important moral and medical purposes. Even basic public health measures like improved sanitation and nutrition were controversial when they specifically benefited women. The idea that pregnant and nursing mothers might need additional food or different working conditions was seen as special pleading that could undermine the principle that everyone should bear life's burdens equally. The cumulative effect of all these factors, medical ignorance, social restrictions, legal powerlessness, cultural expectations, and systematic resistance to change, created what can only be described as a perfect storm of maternal mortality. Victorian pregnancy wasn't dangerous because of some inherent biological risk or unavoidable natural hazard. It was dangerous because an entire society had organized itself in ways that made it dangerous. Looking back from the perspective of modern medical knowledge, the waste of human life is almost incomprehensible. Thousands of women died from complications that could have been prevented with basic hygiene, proper nutrition, appropriate medical care, and respect for their own judgment about their bodies and health. Thousands more died from medical interventions that were more harmful than helpful, performed by practitioners who confused confidence with competence. The personal stories behind the statistics are heartbreaking. Young wives who died giving birth to their first children, mothers who survived multiple pregnancies only to die from infection after what should have been a routine delivery, women who knew they were likely to die but had no choice but to continue having children because that was their only recognized role in society. But perhaps the most tragic aspect of Victorian maternal mortality was how preventable it was. The deaths weren't acts of God or natural disasters. They were the predictable results of human choices, social priorities, and institutional failures that could have been addressed if anyone had considered women's lives worth the effort. The women who died in Victorian childbirth weren't just statistics. They were individuals with dreams, fears, talents, and relationships that were cut short by a system that treated their survival as less important than maintaining social conventions. They were daughters who would never see their children grow up, wives who would never grow old with their husbands, friends who would never share another conversation, and human beings whose potential contributions to the world were lost forever. Some had probably dreamed of becoming teachers, writers, artists, or reformers, But those ambitions were necessarily subordinated to the demands of reproduction in a society that offered women few alternatives. Others might have been perfectly content with domestic life if they could have pursued it without constant risk of death. Many probably just wanted to survive long enough to raise their children and see their grandchildren born. Instead, they became casualties of a war they never chose to fight, armed with nothing but hope, and surrounded by people who confused tradition with wisdom, authority with expertise, and social control with medical care. They faced each pregnancy knowing that it might be their last experience on Earth, but with no realistic way to avoid that risk, or even to minimize it through their own choices and actions. The ripple effects of their deaths extended through generations. Children who grew up without mothers carry that loss throughout their lives, often repeating patterns of early marriage and frequent pregnancy that perpetuated the cycle of maternal mortality. Communities lost the contributions of women who might have become leaders, innovators, or simply the kind of steady, caring presence that makes social life possible. The economic costs were staggering when calculated across entire communities. Every woman who died in childbirth represented not just the loss of her current domestic labor, but the loss of all the productive work she might have done throughout her lifetime. The costs of replacing her household contributions, caring for her surviving children, and managing the social disruption caused by her death multiplied across thousands of families created a substantial drag on economic development. But even more significant than the economic costs were the social costs of organizing society around the assumption that women were expendable as long as they produced children first. This assumption shaped everything from legal systems to medical practice to family structures in ways that limited human potential and social progress. The legal systems that gave husbands complete control over their wives' bodies and medical decisions prevented women from protecting themselves, even when they had the knowledge and desire to do so. The medical systems that prioritized professional authority over practical results prevented the adoption of safer practices that were already known and available. The social systems that equated women's value with their reproductive output prevented recognition that preserving women's lives might be worth some changes in traditional practices. All of these systems reinforced each other in ways that made reform extremely difficult. Legal changes were opposed as threats to family stability. Medical reforms were resisted as challenges to professional authority. Social changes were denounced as violations of natural law and divine will. Any attempt to reduce maternal mortality could be framed as an attack on tradition, morality, and social order. The few people who did advocate for changes faced professional ostracism, social condemnation, and personal attacks that made it dangerous to challenge the status quo. Doctors who suggested that handwashing might prevent infection were treated as troublemakers. Women who advocated for reproductive choice were dismissed as unnatural. Reformers who proposed legal changes to give women more control over their own bodies were accused of promoting social chaos. This resistance to change wasn't just stubbornness or ignorance, though there was plenty of both. It was also a reflection of deeper power structures that benefited from the existing system. Male authority in families depended partly on women's economic dependence, which was maintained by limiting their opportunities and keeping them occupied with frequent pregnancies. Medical authority depended on patients' inability to challenge professional decisions or seek alternative care. Social authority depended on the belief that existing arrangements reflected natural law rather than human choices. Reducing maternal mortality would have required acknowledging that these power structures were not only changeable but actively harmful to the people they claimed to protect. It would have meant admitting that traditional practices could be improved, that professional authority could be questioned, and that women's own judgment about their bodies and health might be worth considering. The intellectual frameworks that supported high maternal mortality were elaborate and self-reinforcing. Religious doctrine that interpreted childbirth pain as divine punishment discouraged efforts to reduce suffering. Medical theories that attributed disease to moral failings rather than physical causes prevented effective treatment. Social theories that defined women's nature as inherently weak and passive justified treating them as incapable of making rational decisions about their own welfare. These frameworks weren't just academic abstractions. They had real consequences for real women facing real dangers. The woman dying of childbed fever wasn't helped by theories about divine will or feminine nature. The woman bleeding to death during a difficult labor wasn't saved by professional authority or social conventions. The woman facing her 10th pregnancy with the knowledge that several previous ones had nearly killed her wasn't protected by legal systems that gave her no choice in the matter. The disconnect between theoretical justifications and practical reality was stark, but it was maintained through a combination of willful ignorance, selective attention, and elaborate rationalization. Deaths that contradicted official theories were explained as exceptional cases, moral failures, or unavoidable tragedies. Evidence that challenged established practices was dismissed as anecdotal, unreliable, or irrelevant. This systematic disregard for evidence that might require changes in practice or policy wasn't unique to questions of maternal mortality, but it was particularly deadly in that context because the stakes were so high and the solutions were often so simple. The same society that could mobilize enormous resources for military campaigns, commercial ventures, and public works projects couldn't seem to manage basic sanitation in birthing chambers or adequate nutrition for pregnant women. The gendered nature of the problem undoubtedly contributed to the lack of urgency about finding solutions. If men had been dying in comparable numbers from preventable causes related to their reproductive functions, it's difficult to imagine that society would have accepted those deaths as natural and inevitable for decades. The fact that the victims were primarily women made it easier to frame their deaths as tragic but unavoidable rather than as urgent public health problems requiring immediate attention. The cultural valorization of maternal sacrifice also made it difficult to acknowledge that these deaths were problems rather than expressions of noble feminine virtue. The idea that women were naturally self-sacrificing and that maternal death represented the ultimate expression of feminine devotion made it harder to argue that preserving women's lives should be a priority. This cultural narrative served multiple purposes. It made individual deaths seem meaningful rather than senseless. It discouraged women from prioritizing their own survival over their children's welfare, and it provided a framework for understanding tragedy that didn't require anyone to take responsibility for preventing future deaths. But the reality behind the cultural narrative was that most women who died in childbirth weren't making heroic choices to save their children. They were simply victims of inadequate medical care, social restrictions, and preventable complications. Their death didn't serve any noble purpose or advance any greater good. They were just waste, human potential destroyed by systems that could have been improved if anyone had cared enough to try. The international context makes Victorian maternal mortality even more tragic, because safer practices were being developed and implemented in other places during the same period. Traditional birth attendants in many cultures had developed techniques for managing difficult labours that were more effective than Victorian medical interventions. Some European countries were beginning to implement public health measures that reduced infection rates and improved outcomes. But this international knowledge was largely ignored or dismissed in England, partly because of cultural chauvinism that assumed English practices were naturally superior, and partly because adopting foreign methods would have required admitting that current practices were inadequate. The same imperial confidence that supported British expansion around the world also supported resistance to learning from other medical traditions or adapting practices that might save English women's lives. The class dimensions of maternal mortality also revealed the hypocrisies and contradictions of Victorian social organisation. Upper-class women were supposedly more refined, more delicate, and more deserving of protection than their working-class sisters. But they were often exposed to greater medical risks because they could afford more aggressive interventions. Working-class women were supposedly coarser and more robust, but they were often weakened by malnutrition, overwork, and inadequate housing. These class differences in mortality patterns should have raised questions about whether wealth and medical attention were actually protective, but instead they were explained through elaborate theories about constitutional differences between social classes. Upper Class women died because they were too refined for the crude business of childbirth. Working class women died because they were too degraded to benefit from proper medical care. The fact that both groups were dying at alarming rates was treated as evidence of different, but equally natural vulnerabilities rather than as evidence of systemic problems. The professional interests that benefited from maintaining the status quo were also important factors in resistance to change. Doctors who had built careers on their supposed expertise in managing childbirth had little incentive to admit that their interventions were often harmful, or that traditional midwives might achieve better results with simpler methods. Medical schools that taught elaborate theories about feminine physiology and reproductive pathology had institutional investments in maintaining those theories, even when evidence suggested they were wrong. The pharmaceutical industry that sold patent medicines to pregnant women had obvious financial interests in maintaining demand for their products, regardless of whether those products were actually helpful or harmful. The manufacturers of medical instruments had similar interests in promoting surgical interventions and complex procedures that required specialized equipment. All of these professional and commercial interests created constituencies that actively opposed reforms that might reduce maternal mortality, if those reforms would also reduce demand for professional services or commercial products. This created a situation where the people with the most influence over medical practice and policy had personal incentives to maintain practices that were killing their patients. The information barriers that prevented women from making informed decisions about their own care were also crucial factors in maintaining high mortality rates. Women weren't taught basic anatomy or physiology, weren't informed about the risks and benefits of different medical interventions, and weren't given access to information about alternative approaches to pregnancy and childbirth. This ignorance wasn't accidental. It was actively maintained through educational systems that excluded women from serious study of science and medicine, social conventions that made discussion of reproductive topics taboo, and medical practices that treated patients as passive recipients of professional expertise, rather than as participants in their own care. The result was that women faced the most dangerous experience of their lives with almost no reliable information about what to expect, what choices they might have, or how to recognize and respond to warning signs of complications. They were entirely dependent on the judgment of medical professionals who often knew less than they claimed and had interests that didn't always align with their patients' welfare. Even women who suspected that their medical care was inadequate or dangerous had few alternatives available. Changing doctors was difficult and expensive. Seeking care from midwives was increasingly stigmatized as backward and dangerous. Self-care was discouraged and sometimes criminalized. Women's own observations about their bodies and pregnancies were dismissed as unreliable and irrelevant. This systematic disempowerment of women in their own healthcare was justified through elaborate theories about feminine psychology and physiology that portrayed women as incapable of rational thought about their own bodies. The same women who were expected to manage complex households, raise multiple children, and maintain social relationships were supposedly too emotionally unstable to participate in decisions about their own medical care. The contradictions in these attitudes toward women's capabilities were stark but rarely acknowledged. Women were simultaneously considered too weak to handle physical activity, but strong enough to survive repeated pregnancies and childbirth without complaint. They were too emotional to make rational decisions, but expected to maintain perfect composure during labor. They were too ignorant to understand their own bodies, but blamed when things went wrong. These contradictory expectations created impossible situations where women could never succeed according to social standards. If they expressed fear about childbirth, they were considered weak. If they approached it with confidence, they were considered immodest. If they followed medical advice and died, they were tragic victims. If they questioned medical advice, they were dangerous rebels. The psychological effects of living under these contradictory expectations while facing repeated life. Threatening experiences were rarely acknowledged, but must have been devastating. Women had to maintain social facades of calm acceptance while processing trauma, grief, and terror that would challenge anyone's mental health. The support systems that might have helped women cope with these stresses were often inadequate or non-existent. Female friendships were encouraged, but circumscribed by social conventions that limited honest discussion of difficult topics. Family relationships were structured around male authority in ways that prevented women from seeking help or expressing vulnerability. Professional support from clergy or physicians was available, but filtered through belief systems that attributed women's suffering to moral failings or natural weakness. The cumulative effect was to isolate women with their fears and experiences in ways that made each pregnancy feel like a solitary battle against overwhelming odds. The knowledge that other women faced similar dangers wasn't comforting, when that knowledge couldn't be translated into practical support or effective action. The long-term consequences of this system extended far beyond the immediate mortality statistics. Surviving women carried physical and psychological scars that affected their health and well-being for the rest of their lives. Children who lost mothers faced developmental challenges that could persist throughout their lives. Families and communities developed cultures of fear and resignation around pregnancy that were passed down through generations. The social progress that might have resulted from women's contributions to literature, science, politics, and social reform was lost when those women died in childbirth or were weakened by repeated pregnancies and poor medical care. The economic development that might have resulted from women's productive labor was diminished when that labor was interrupted by frequent pregnancies, extended recoveries, and premature death. The human knowledge that might have been developed through women's experiences and observations was lost when those experiences were dismissed as irrelevant, and when the women who had them died before they could share their insights with others. The social innovations that might have emerged from women's perspectives on family life, community organization, and human relationships were prevented when women were excluded from public discourse and decision-making. In the end, Victorian maternal mortality represented one of history's great preventable tragedies, a systematic waste of human life and potential that resulted not from natural disasters or unavoidable circumstances, but from human choices about social organization, medical practice, and cultural values. The women who died weren't victims of fate or biology, but of systems that could have been changed if anyone had considered their lives worth the effort required to change them. The legacy of that tragedy extended far beyond the Victorian era itself, influencing attitudes toward women's healthcare, reproductive choice, and medical authority that persisted well into the modern era. Understanding that history helps explain not just why so many women died in Victorian childbirth, but why it took so long to develop systems that prioritized women's health and survival over other social, professional, and commercial interests. The story of Victorian maternal mortality is ultimately a story about power, priorities, and the consequences of treating some people's lives as less valuable than others. It's a reminder that medical progress isn't automatic or inevitable, but depends on social choices about what kinds of problems deserve attention and resources. And it's a testament to the resilience of the women, who faced those dangers with courage and dignity, even when the systems that surrounded them failed to provide the support and protection they needed and deserved.